Thank you, Terry, for the introduction, and I want to also thank Winston Wong for convincing Karen to invite me to the roundtable today. Zero Divide, as Terry said, is an organization. We have been primarily a grant-making organization and have moved to a consulting practice because the work that we funded around the adoption of technology as it relates to underserved communities really required the dissemination of some best practices and some methodologies that really didn't exist in the field. And so we found that there was a real demand for that, and so we have sort of morphed ourselves into an opportunity that takes advantage of an opportunity to really sort of spread some best practices and to really uncover some of the issues that really prevent technology from being most impactful in the social sector. So I'm going to do a little bit of a big picture, as Terry said. And just to give you a little bit of my background, I started out in 1979 at a community health center in Oakland that served non-English speaking Asian immigrants speaking 8 to 20 different Asian languages. I started as a billing clerk, and so I had all the ICD-9 codes memorized in my head because I had to translate the routing slips that the physicians, like Winston back then, wrote on pieces of paper onto the billing ledger, translate them onto a HCFA 1500 form, put them in the mail, and then wait for reimbursement. So that's sort of where I started from. I ended up doing the finance work at the clinic, moved on to an advocacy organization, minority health advocacy organization for 15 years that did that work nationally, and have now found myself at the intersection of technology and health disparities. One of the other hats that I wear is as a board member of a large health system called Dignity Health. Some of you might be aware of Dignity Health. It's based in the West Coast, but probably second, third largest faith-based health system, formerly faith-based health system in the U.S., and have a big picture perspective from serving on that board. So just to get into this, we know that the integration of HIT and e-health it's prompted primarily by policy, at least from the federal level. And we've got HIPAA and high-tech pre-ARA. We've got now the meaningful use incentives, and we've got ICD-10 imminently coming. So those kinds of large policy things have driven a lot of the digitization and the technologization of healthcare. However, even without those policy initiatives, the industry itself, as you all know, has begun to change itself from business imperatives and from a range of other imperatives that really converge all of this together. The policy initiatives as well as the industry, separate and apart almost from policy itself. And at the core of it is population health management, and we all know that we're all trying to figure out what is the best way now that we're moving from a fee-for-service to a fee-for-value world. How do you do population health management? In this slide, we have IT and data at the core in an ecosystem that says you have to have data and the technology that moves that data in a virtuous loop in order to be able to achieve your objectives around population health management. However, from our point of view, this is really what population health management is about. You put the patient in the center, and the patient is part of an ecosystem that has to now navigate an integrated delivery system that in many cases, most of us have experienced is very, right now, fragmented, right? There's not a lot of connection between all of these pieces of the integrated pie that a patient and the patient's provider has to navigate together in order to be able to achieve well-being and good outcomes, reduce cost, and to really sort of help the patient and the provider do better care management. Around all of that, of course, is all of the technology that needs to feed into that ecosystem. So whether IT is in the middle or the patient is in the middle, IT is sort of a constant. From Zero Divide's point of view, we look at it right now just in terms of, we work primarily with providers in the health space. We work with community-based providers of both primary care and wellness and prevention services. And so what we're trying to get them to do is move along a path of digital maturity. Most of them are standing outside, the sort of the EHR world. I think at this point, if you are familiar with community health centers or primary care medical homes, a very small percentage of those community clinics have adopted a working EHR, and most of them have not or will not achieve meaningful use anytime soon, meaningful use one anytime soon. Most of them are going to, and they're navigating around mostly consumer-facing processes that stand outside an integrated system, right? And so that incorporates anything from social media, wearables, in the mobile context, to any other way that a patient is seeing themselves either seeking or interacting or providing themselves with health-related data. On the institutional side, whether it's a community clinic, or a health system, most are dealing with, the kinds of large-scale data initiatives that are being pushed that require an EHR, big data, and all of that. So those two things are not coming together anytime soon, and most of the speakers this morning really sort of reference this sort of state in one way or another. And this is what we're sort of confronted with for the time being, probably in the very foreseeable future. It's a long, expensive, difficult, complex, both infrastructure, cognitive infrastructure of capacity building, change management, and a lot of money in order to get this, money and time to get this moving. However, patients still want to be able to take advantage of what technology offers them at this point in time. This is 2-year-old data, and even 2-year-old data with a survey population that is mostly English speaking, you'll see that there are, there is high demand for everything from using mobile for prescription adherence to appointment reminders, and then for sort of procedural messages. Now, this might not reflect, at this point in time, the sort of medically underserved populations or the disadvantaged populations that we're all sort of focused on, but it does give you a sense of where is the majority of the population going, where are commercial and industry interests moving in order to address that majority population, who's going to be left behind if they don't become part of the statistic, right? There'll be a different statistic. And it'll be a much more dire statistic, I think, in terms of a lot of indicators if we don't move quick enough and appropriately enough. So Zero Divide over the last several years has been doing a lot of research, and we do primarily convenience research, because we feel like we need to move quickly in the marketplace in order to be able to determine what are the barriers and what are the issues that the kinds of populations that we're most concerned with, low income, immigrant, non-English speaking, disabled, rural, complex insurance households and so on, what do they face in order to be able to mainstream themselves into this movement that is called digital health, what we call and we frame as e-health equity. So some of, we have a paper that we published earlier this year that goes through some research that we did, comprehensive lit review, some key informant interviews, focus groups, convenings, a survey, really sort of compiled all of the data sources that we could possibly get at the time to really sort of determine what could we say about the status of the intersection of health and technology as it relates to underserved populations. And here's just some data to share with you about that. So just for, to simplify, we categorized the kinds of what we call e-health tools in 3 categories, primarily at a high level, the sort of infrastructural tools that you see primarily in health systems, PHRs, EHRs, and portals. Meaningful use very much tied to that. A lot of the disease management tools that many of the speakers this morning talked about focused on chronic disease, piloting programs, and then the text messaging, which is just simple mobile in order to be able, as an e-health tool. So what we found with the SMS and e-health apps, and none of this is new to you, it's basically a confirmation and a reiteration of things that a lot of folks have said, but the biggest issue is a lack of scale. So these things work, right? Text for Babies and a lot of these sort of texting apps, they do work, right? And they do reach with the right kinds of outreach and interventions and partners. They do have some effect, but they have yet to be brought to scale. And somebody spoke to it earlier about sort of the lag between the sort of academic process and all of the requirements attendant to that, and then the community-based process, right? And the issues attendant to piloting and testing and bringing things to scale and market from a community base. And so the reality is there isn't anything particularly that addresses the communities that we're most concerned about that has yet scaled, right, in a way that is meaningful. And that's the crux of it, whether it's funding, whether it's the workforce, change management issues, the tensions between industry, research institutions and community-based organizations. We're not sure what all of that is, and we just know that things that do work are not getting fast enough into the hands of people that can use them. The apps that we have seen, they're not tied, they're not integrated into the hospital and health system EHRs, presenting a lot of challenges, and they've been primarily implemented through pilot programs. In the speed dating session over there during lunch, one of the folks who was asking me about one of the apps that I was showing, it's like the hardest thing is to get the money for the development of the app in order to be able to take it to beta or to market, right? Who funds that, right? And we're traditionally looking for academic resources within your own institutions, government funding, philanthropic funding. That's not going to happen soon enough for this to happen, right? We have a speaker later on who's going to tell us how maybe the private sector might be a more willing partner and should be a more willing partner to get some of these things to market quickly. I'm not going to go over this because people know that there is an environment that is ready, has high demand for or some readiness for at least mobile through the data here. The other sort of at a high level e-health tools that are in the marketplace are PHRs and portals, and that's where again the federal initiatives really sort of provide the incentives for a lot of resources to go into the development of these. But again, they're not tied to existing. They're not tied to enterprise EMR systems. Even the Kaisers of the world, are and I guess Brian will talk to you about this. The challenges they've had in implementing their patient portal. I'm on the board of Dignity Health, and we're just now implementing a patient portal solution that's going to take us 3 years to roll out, right? Hopefully not, but that's what they're projecting. And so usability, poor usability and design was talked about this morning. So all of these problems are things that we have to address, not just in your particular experiment, right? But on an industry-wide and a population health scale, right? And then again, confirming based on our research the barriers to e-health adoption, m-health adoption, digital health adoption, whatever definitions people want to use. The digital divide, Not enough attention to the issues of broadband, and Wi-Fi access, affordable Wi-Fi access. People talked a lot about design and usability, and talked about reading literacy levels. We're talking about linguistic and cultural competency issues around usability and design. Disability, so this is physical and cognitive disabilities as well. And then the education awareness, which never gets enough attention, right? So you can have a cool tool ready to go, perfectly designed. Now, what's the distribution plan? What's the outreach plan? Do you have partners that you might have local community-based partners that have helped in a design, but is there a national organization that community-based organization is tied to, that can help the dissemination across the country or in many different settings? We followed this other research up with more recent research where we did some focus groups across the country with a specific population of minority women ages 30 to 64 who were making the health decisions in their household, who themselves were at risk for a chronic disease. And because we wanted to make sure that we got the users, the beneficiaries, and they confirmed the same things. They have access to the internet, maybe not the highest speed or not the most affordable, but they have it. They think it's important. They're discouraged by what they see, though. It doesn't reflect them. And they want personalized, culturally competent technology solutions. So here's some recommendations from that set of focus groups. Digital literacy, not just of the consumers, but of the safety net providers who are now having to interact with their patients around the use of these tools, right? And so not enough attention is being paid to, I think, the safety net providers. Again, usability, user-centered design, supporting technology capacity building for the safety net providers. So right now, again, just using FQHCs or community health centers as an example of the capacity that they are being resourced to build is really all around EHR adoption, right? There is not a lot of support from a traditionally federally and government-funded source that allows for the testing and using and the incorporation of tools, whether they be the consumer-facing tools or the other infrastructure tools that support operational processes within their clinics that's available. And then finally, around some policy approaches. So we think that there is a complementary top-down and bottom-up set of approaches that need to be sort of combined. And this just sort of, again, just sort of in a bulleted form, much more comprehensive information about what could be done. So meaningful use is really the big stick that's going to move. It's, even though we rail against it, it's still the big stick that's going to make a lot of difference, I think, ultimately, because everybody basically has to comply with meaningful use. There's opportunities with meaningful use 3 to build in class standards, the cultural and linguistic access standards, as part of the requirements for meaningful use 3. Again, more innovation grants, right, with real-time, sort of rapid cycle processing around these pilots. And then a central database or registry of all of these things, all these wonderful things that folks talked about this morning and that were demonstrated at lunch. How do you know that they exist, right? How do you know which ones have sort of, gone through 20 IRBs and 4 clinical trials, or those who have really just been developed from the commercial sort of venture process, a type of startup process that might still have the same viability and reliability, but nobody knows where to find them. And then bottom up, and again, things work. There are proven technology tools and e-health tools out there that really do improve the health and well-being and lend to population health management and disparities, breaking down the disparities in health equity. But we need to make sure that the consumers and the patients and their providers and their communities know about them and are able to use them. Opportunities to bring patients and developers together and really sort of not just do it in a hackathon type of environment, really have strategic relationship and partnerships where if IP is developed as part of a hackathon, there's shared IP. Somebody referenced the need for academic institutions to share their research dollars. Well, how about sharing IP, right? And the revenue that might be generated from that. And then again, community e-health pilots. And I think that there is some hope as I go to a lot of the tech and health conferences, and I've seen more and more that there is an attentiveness to the need to bring providers, patients, investors, innovators together to really begin to do deep dives into solving some of these barriers. And so there is some hope, and I think people have to be open to that, to not stay in the enclaves that which we are comfortable, or try to win people over to your way of doing things. That's just not going to work, right? And we all know that mentally, and we know that experientially now. Now, what's going to be the catalyst that gets us to open up to, it's the equivalent of sort of open, we're going to end up being one big open data, shared data, big data platform. And I think people in the room, you all know that, and so you're part of the solution, and you're a big part of the solution. And so I would hope that because of forums like this, that there will be opportunities for more of this to happen in an accelerated way. Thank you.